During peripheral VA ECMO cannulation, what is the primary purpose of placing a distal perfusion catheter, DPC, in the femoral artery? A. To increase the total flow rate of the ECMO circuit. B. To prevent limb ischemia distal to the arterial cannulation site. C. To monitor continuous arterial blood pressure. D. To allow for easier weaning of the arterial cannula. Answer: B. To prevent limb ischemia distal to the arterial cannulation site. Explanation: large arterial cannulae can occlude blood flow to the lower limb. A DPC redirects a portion of the oxygenated blood flow distally to ensure the leg remains perfused. Which cannulation configuration is most appropriate for a patient with isolated respiratory failure and preserved cardiac function? A. Veno-arterial, VA. B. Veno-venous, VV. C. Veno-pulmonary, VP. D. Veno-veno-arterial, VVA. Answer: B. Veno-venous, VV. Explanation: VV-ECMO provides gas exchange, oxygenation and CO2 removal, but relies on the patient's own heart to circulate that blood. VA-ECMO is reserved for cases involving circulatory/cardiac failure. In VV-ECMO, recirculation is a common phenomenon. Which of the following best describes it? A. Oxygenated blood from the return cannula is immediately pulled back into the drainage cannula. B. Blood flows backward through the oxygenator due to pump failure. C. The patient's cardiac output exceeds the ECMO pump flow. D. Blood leaks from the arterial line into the venous system. Answer: A. Oxygenated blood from the return cannula is immediately pulled back into the drainage cannula. Explanation: recirculation reduces the efficiency of VV-ECMO because the fresh blood doesn't reach the patient's systemic circulation, it just loops through the circuit. When preparing to wean a patient from VV-ECMO, which challenge is typically performed first? A. Decreasing the pump RPM to 0. B. Clamping the drainage and return lines. C. Turning off the sweep gas, oxygen flow, to the oxygenator. D. Reducing the heparin dose by 50%. Answer: C. Turning off the sweep gas, oxygen flow, to the oxygenator. Explanation: in VV-ECMO weaning, we keep the blood flowing, to prevent clots, but turn off the gas exchange. If the patient's lungs can maintain adequate PaO2 and PaCO2 without the sweep gas, they are ready for decannulation. What is a Seldinger technique in the context of ECMO cannulation? A. A surgical cut-down to expose the vessel. B. A method of percutaneous vessel entry using a needle, guide wire, and dilators. C. A specific way of suturing the cannula to the skin. D. The process of priming the circuit with albumin. Answer: B. A method of percutaneous vessel entry using a needle, guide wire, and dilators. Explanation: most modern ECMO cannulations are performed percutaneously via the Seldinger technique, which is less invasive than open surgical exposure. During VA-ECMO weaning, bridge or minimal flow trials are conducted. Why is the flow rarely dropped below 1 to 1.5 liters per minute during these trials? A. To prevent the patient from becoming hypotensive. B. To avoid the risk of thrombus, clot formation in the circuit/cannulae. C. To maintain the FiO2 at 100%. D. To prevent the north-south syndrome. Answer: B. To avoid the risk of thrombus, clot formation in the circuit/cannulae. Explanation: low flow states in the ECMO circuit increase the risk of blood stagnation and subsequent clotting, which could lead to a stroke or systemic embolism when flows are turned back up. North-south syndrome, Harlequin syndrome, is a complication of peripheral VA ECMO. Where is the deoxygenated blood typically seen? A. In the lower extremities only. B. In the upper body, head and right arm. C. In the ECMO drainage line. D. In the distal perfusion catheter. Answer: B. In the upper body, head and right arm. Explanation: this occurs when the heart recovers but the lungs haven't. The heart pumps poorly oxygenated blood to the upper body, while the ECMO returns oxygenated blood to the lower body via the femoral artery. Which imaging modality is considered the gold standard for verifying the tip position of a dual-lumen VV-ECMO cannula, like the Avalon? A. Chest X-ray. B. Transesophageal echocardiography, TEE. C. Fluoroscopy. D. Both B and C. Answer: D. Both B and C. Explanation: dual-lumen cannulae must be precisely positioned so the return jet is aimed directly at the tricuspid valve. TE and fluoroscopy provide the real-time visualization needed for this. What is the primary indicator of successful weaning during a VA-ECMO turndown trial? A. An increase in the ECMO sweep gas requirement. B. A stable left ventricular ejection fraction, LVEF, greater than 25 to 30% on echo. C. A decrease in the patient's heart rate. D. A mean arterial pressure, MAP, of exactly 60 mm of mercury. Answer: B. A stable left ventricular ejection fraction, LVEF, greater than 25 to 30% on echo. Explanation: cardiac recovery is the goal for VA-ECMO. If the heart can maintain an adequate LVEF and VTI, velocity time integral, as ECMO support is reduced, the patient is a candidate for decannulation. Which vessel is most commonly used for the drainage, venous, cannula in peripheral VA-ECMO? A. Internal jugular vein. B. Subclavian artery. C. Femoral vein. D. Radial artery. Answer: C. Femoral vein. Explanation: the femoral vein is the preferred site for drainage in peripheral VA-ECMO due to its size and ease of access, allowing the cannula tip to reach the inferior vena cava, IVC.